Thank you so much. I would like to thank Dr. Vitull for providing this opportunity to present a talk. I still remember the day we got a transplant license. I received a call from Dr. Vitull. Okay, we should have a talk regarding the transplantation. What is the basics? So I will just try to keep it as basic as possible and a concise one. We all know the CKD stages and CKD 5 when GFR is less than 15 ml per minute, and that is where we label the patient as ESRD and stage renal disease, and that is where the renal replacement therapy in the form of hemodialysis versus the kidney transplantation, it actually intervene. Most common cause of ESRD, we all know diabetes. India is a diabetes capital of the world. Punjab is leading in India. Second most common cause, hypertension. And other causes include glomerulonephritis, pyelonephritis, obstructive uropathies, polycystic kidney disease, and other vascular diseases. Causes of death in ESRD, most common, heart disease, sepsis, and stroke. Renal replacement therapy, just a quick one. We know it is of two types, dialysis versus kidney transplantation. Dialysis can be peritoneal dialysis, hemodialysis. This is just a pictorial picture. What is hemodialysis? What is peritoneal dialysis? We all know. I will not go into details of these slides. Indications of dialysis, just a quick review. Refractory hyperkalemia more than 6.5, when urea more than 50 millimole per liter. Refractory metabolic acidosis, and other end organ damage like pericarditis, encephalopathy, neuropathy, and refractory volume overload, etc. Again, peritoneal dialysis, we all are aware. I will not go into details. It was just for the documentation purpose. This is the slide I want to focus more on. Why transplant? Why not dialysis? So the advantages, the transplant, especially when done as a preemptive transplant without any dialysis in between, it improves the life expectancy. It improves the quality of life. Transplanted kidneys, they produce erythropoietin and hence reverse the anemia associated with the chronic kidney disease. Better exercise capacity develops for the patient. It frees, of course, from the patient of burden of the dialysis and the complications which are associated with the dialysis. And of course, if we see a long-term data, it is more cost-effective compared to the dialysis. Rationale, no fluid or dietary restrictions. Of course, pregnancy is possible after a successful kidney transplant. And life expectancy is better in transplant population. 5-year survival is more than 85% compared to less than 50% of the patient who are on dialysis. The longest kidney transplant survival patient is from PGI Chandigarh, who is more than 38 years now after kidney transplant. Just a glimpse of the legal authority. This is the act which controls the kidney transplantation. This is the Transplantation of Human Organs and Tissue Act, that's called THOTA. It was in 1994 that act was passed, but there have been many modifications that has happened. 2011 was the recent modification that was done. This act defines various terms such as brainstem, death, donor, hospital, etc., providing clarity in the legal proceedings related to organ transplantation. Of course, it regulates the removal, storage, and transplantation of human organs and tissues, and it prohibits the commercial dealings and mandates authorization for the transplantation. There is a committee that is called Authorization Committee that is constituted or recommended under this act, which mandates the establishment at the state and the national level, and these committees, they oversee and regulate the organ transplantation procedures, ensuring the compliance and the ethical standards they are followed. And of course, the penalties are very strict. You must be, listening these days on and off that the penalties that are the consultants or the doctors they face who doesn't follow the legalities of this act. Just to name, this act comprises 3 main regulatory bodies. One at the national level, it is the NOTO. Then at the regional level, this is the SOTO, State Organ and Tissue Transplant Organization. And then it is ROTO at the regional level, ROTO, and it is State Organ and Tissue Transplant Organization, that is SOTO at the state level. NOTO is the apex body that is located in the New Delhi, in the capital. And it regulates, it mandates the legalities or the framework that is there to be followed for the kidney transplantation. And ROTO, Regional Organ Tissue and Transplant Organization, that is for us, it is in Chandigarh, it is in the PGI. And the state, SOTO, in our state is in GMC, Patiala. Selection of patient's recipient is very important when we talk about the kidney transplantation, and it is the age as per se is not a contraindication. Previously, there were the criteria in which age more than 60 was contraindicated, but these days, more than 60 extended criteria donors, they are eligible for kidney transplantation. And uncontrolled infection and malignancies, they are still the contraindications, and malignant disease should be deferred for a disease-free period of minimum 2 years before proceeding for the kidney transplant recipient. Absolute contraindications, active IV drug abuser, active systemic sepsis or transmissible disease, unreconstructible vascular disease, significant psychological barriers, malignancy, of course, within 2 years, minimum 2 years we take it. And exceptions for the malignancies are when they do not metastasize, that is primary brain tumors, non-melanotic skin cancer, and in situ CA of cervix. When we select the patient, of course, we do the color Doppler for the vasculature, because there are the one where we have to anastomose the transplanted kidney. Urodynamics, to be sure that the bladder of the patient is working properly so that the transplanted kidney doesn't face any issues related to the bladder. And patients should be listed in transplantation preemptively. That is, it has been seen in the long-term data that preemptive kidney transplant has more success compared to the transplant which happens after the hemodialysis. And in the polycystic kidney disease, I will have another slide on this. When the size of the kidney is large enough that we cannot place the transplanted kidney into the iliac fossa, then we do pre-transplant nephrectomy and PCKD. This is the slide which depicts what are the indications of removing the native kidneys in the transplant recipient before we transplant a donor kidney. The proteinuria, which is not controlled by the medical management, anti-GBM antibodies when they remain persistently elevated, recurrent pyelonephritis resulted in the recurrent sepsis and hospital admissions, ADPKD, of course, when they extend, the kidneys are large enough to extend up to the iliac fossa, and we need a space to place the transplanted kidney. Stones, symptomatic stones, which cannot be cleared in the PCNL, we have to remove the kidney. Tumors, of course, high grade without autosomal recessive factor, and bilateral VUR grade 4 or 5, which is actively resulting in the UTI, we need to remove those kidneys. There are a risk of recurrence in the allograft when it is transplanted in the primary in the patient, and the recurrence includes the primary diseases, that is hemolytic uremic syndrome, MPGN, membranoproliferative glomerulonephritis, primary oxalosis, primary focal segmental glomerulosclerosis, Fabry's disease, myelofibrosis, IgA nephropathy, to name a few. They have a high chance of recurrence. But ADPKD, cystinosis, renal dysplasia, and Alport syndrome, without anti-GBM, they have less chances of recurrence. Now the donor selection. Donor selection, more than 60 age donors. Earlier, they were not recommended as per the law, but now they are part of extended or expanded criteria donors. So, depending upon whether comorbidities are there or not present, age more than 60 can be accepted as a donor. Age 50 to 59 with 2 or more risk factors, that is hypertension, elevated creatinine just before the recovery of the organ, that is 1.5, and death from a stroke. Standard criteria, of course, less than 60, that is 18 to 60. The mean waiting time for kidney transplantation is on an average in India around 3 years. And there are shortages of other organs like heart, lung, liver, and pancreas. Disease donors, of course, the donors are of 2 types, live donor and disease donors. And the disease donors are usually the brainstem dead donors that we accept as the donors. And live, of course, they are related or first degree relatives and, of course, the wife. Some of these stats, Disease donor kidney transplant, it is clearly showing that in India, in 2022, 1,541 disease donor kidney transplants has happened. It is increasing day by day as more and more institutes, they are starting doing the cadaver transplant. And compared to the live, they are 10,164. Majority of disease donors, they are being done in South India. In PGI, it's a very good program in disease donor. And live organ transplantation, majority is successful, or majority people are doing in North India side. Now, what is the advantage of live donor over a cadaver donor? It is definitely a healthy individual, which is without comorbidities. Rigorous assessment process is there. And there are, organ functions immediately after transplant. Of course, the kidney starts, because it's a functioning kidney that we have taken, compared to the cadaver in which, the patient is the brain dead, and we don't know when actually the kidney will start functioning. And long-term outcomes are definitely superior. Already I discussed that preemptive transplant is better when it is done without starting on the hemodialysis. Similar, already I have discussed that what are the advantage of the live donor over a diseased donor. Components of live donor. Of course, when it comes to the donation of the kidney, there are many components that come to the picture. Of course, the primary, the main, the star, the center of attraction, the main person who start, the thinking about the transplant is a nephrologist, because the patients, they are landing up for the dialysis with a nephrologist. And he then plans about the kidney transplant, which patient actually is suitable, Then, of course, other factors, of course, transplant surgeon is required. Social workers, which counsel the patient. Financial counselors, we need to see whether the patient can afford it. Although these days, in many government institutions, there are different funds that are there to support the patient for the kidney transplantation. Psychologically, the patient has to be counseled. This is a very, very important counseling. Psychologically, the patient has to be counseled about, the effects of transplant. What will be the effects immediately? Kidney might not function. There may be a risk for hyperacute rejection. There may be a risk for acute rejection, and patient has to take the immunosuppressants lifelong. Patient has to be prepared psychology for all these things. So psychological counseling is one of the most important. So it's a multidisciplinary approach, not a single approach. So multiple departments, they involve in this. If ladies are there, gynecology is very important. The counseling is very important. Of course, now the evaluation, how we evaluate, we start with the history. Of course, detailed health questionnaire about the patient, donor education consent, multiple vital signs are taken. Definitely evaluation by the mental health or psychologist is done. Psychological evaluation, already I have discussed that it is the most important. Then family pressure or financial incentive to donate should not be there. This is the main crux of the act that I was discussing. So this thing, that family pressure or financial incentive, if this is there, then there is a problem. So these two things has to be ruled out. That is why there are multiple steps, the multiple committees, multiple legal committees are there. They check for the documents of the donor, whether it's a real donor, it's not a faking donor, and there are there shouldn't be any hidden information that should not come up, because these are the problems that are faced later on, and that lands you in a legal trouble. Components, of course, the investigations that we do, we measure the blood pressure for the donor. 24-hour blood pressure monitoring is there. 24-hour urine assessment is there. Recently, we have started, evaluating the patient, the donors, because we are sooner going to start the transplant here. And we got a donor who had recently diagnosed hypertension. Ideally, the recipient is very good, a young age female. The donor is found to have a hypertension which is newly diagnosed, and 24-hour urine protein was more than 3 grams. But this was newly diagnosed. We treated the patient, and after 3 months, almost now the proteinuria is gone, and it is listed as extended criteria donor with us. Diabetes has to be ruled out. Metabolic workup, of course, abiotyping. The general normal profile like ECG, chest X-ray, cross-match, HLA, I will discuss in few slides. So these are European Association of Urology 2024 guidelines on live organ donation, and it recommends that strong guidelines are there regarding determining the ABO blood group and HLA antigens in all candidates of the transplant. Test both the donor and recipient for HLA DQ And other guidelines also very strong. I'll just quickly skip it and go to the other slides. Matching donor, of course, very important. This is the slide that I want to focus. So this is the HLA typing. We all know there are two classes of HLA, 1 and 2. And the loci for 1 are HLA A, B, C, and for 2 are D, P, R, and Q. And most important that we have to, work up is A, B, and D, P, Q, and C. So each HL locus that we have has 2 genes. So this is how we match them. 0, 0, 0 is the mismatch, that is the ideal one, which is we actually want. And 2, 2, 2, that is we write it as 0 by 6 mismatch or 6 by 6 mismatch. So the higher is the number of the mismatch of these 3 genes, the higher chances of rejection are there. So 0 by 6 mismatch is the best one that we should get. ABO, of course, these days, the importance of ABO matching, of course, it is there, but still, these days, the immunopathology has improved so much that now ABO incompatible transplants that are being held. And my next slide is depicting this ABO incompatibility, how we are going for ABO incompatible. Basically, we desensitize these antibodies. And rituximab anti-CD20 drug is started date 28 before the transplant, and at the 3-4 days before the transplant, and of course 1 week after the transplant, we go for plasmapheresis. And the tacrolimus and the other immunosuppressants that are commonly used, they are started on day 0. And of course, the IVIG or basiliximab is given at D0. So this is the desensitization protocol which helps us perform the ABO incompatible kidney transplantation. In the live organ donation, continuing, we have to rule out the infectious diseases like HIV, hepatitis B and C, and syphilis, TB, and other diseases as per the region. Of course, malignant diseases we have to rule out as per the age, and PSA for the prostate cancer, and other for the gynecological examination we have to go for pap smear, colonoscopy, mammogram, and 2D echo and PFT CTs to rule out any malignancy. Donor and stones, I told you we have to clear the donor first of the stones before starting with the transplant. It's important. Donor and hypertension, there are different criteria. These days, we have some extended criteria that a patient who is hypertensive on 1 or 2 antihypertensives can be taken up for the as a donor. Donor and albuminuria, I just gave an example that newly diagnosed hypertensive patient with significant albuminuria, it was treated and the patient is now labeled as extended criteria donor. Donor and pregnancy should not donate while the patient is pregnant and should not be excluded from donation solely because they desire to conceive children. May be acceptable if their long-term post-donation risks are acceptable. Malignancy, of course, 2 years malignant-free survival can be acceptable. Marginalized donors, of course, those donors who have diabetes, hypertension, coronary artery disease, they are obese. This family history of kidney diseases, endocrine disorders, respiratory disorder, neuropsychiatric disorders, and skin cancers. They are labeled as medically marginal. This is our checklist practice that we are adopting for the donor details. The basic details are there. All demographic profile is noted. Of course, the comorbidities are noted. And in the lower end, cardio, pulmo, anesthesia, psychiatry, urology, these are very important counseling, and the fitness from these departments is very important. And of course, the basic profile is done. We go for ultrasound, we go for CT, angio for the donor to look at which side kidney we want to take depending upon the vasculature, arteries, number of arteries in the donor kidney, 1 or 2. Majority of times we prefer the left kidney because the left renal vein is longer in length on the left side compared to the right. And we do DTPA to see the absolute GFR and the percentage of function on the both kidneys, and better kidneys left with the patient, with the donor, and relatively less functioning kidneys taken up for the transplant. Of course, the infectious profile and the clearances are very important. This is the medical fitness certificate performer that we are using. It is there on the SOTO site. My next 3-4 slides I'll quickly go through. This is basically for the surgical aspect, how we do. Majority of time I told we take the left side of the kidney and we transplant into the patient's right iliac fossa, where the renal artery is majority of time transplanted end to side with the external iliac artery. and renal vein with the external like vein, and ureter with the native bladder. Live donor surgery, majority of time donor surgery these days, everywhere it is done with the laparoscopy, and it is best to retain, the best kidney is left with the donor, already I have discussed. This is more of surgical that we prefer, majority of time we prefer the left side because left renal vein is important, but sometimes there are multiple renal arteries on the left side, so we have to take up the right side. In the right side, if we are taking, the vein size is small, so in that case, what we do is after we have mobilized the kidney laparoscopically all around, we open up the patient and we take a patch of the IVC with that to improve the length. Recipient preparation, majority of times it is supine position, and of course Gibson incision is there. Under GA we do, it is Gibson incision, inverted hockey incision in the right iliac fossa, and kidney is placed in right iliac fossa. In the left side, indication is when already a patient has undergone one transplant, it has failed and there is no space on the right side, and the patient is undergoing second transplant, we place it on the left side. Retroperitoneal surgery, already I have described that the vessels, how majority of time it is anastomosis, arteries are and veins are anastomosis to the external iliac. Internal iliac is used more commonly when there is accessory renal artery alongside. Reperfusion, this is more of a surgical. After we do ureteric, it is anti-reflex Lichgroig operation that we mostly do. This is the surgically, I have explained what I have explained. This is the Gibson incision that we do on the right iliac fossa, and inverted hockey stick incision. And this is how we open the external oblique aponeurosis and rectus sheath. We don't divide the muscle in this, and this is how we reach the retroperitoneum, and we apply the sling around the vessels. And inferior epigastric vessel, this is the yellow line, this is preserved because any accessory renal artery is there, we can anastomose it with the inferior epigastric. And this is how the vessels, these are the vessels shown. We hook these vessels with these slings and we dissect them, and this is clear. This is how we denude the external iliac vein, external iliac artery, divide the tributaries, clear very clearly with the cautery, so that later on lymphocyl chances are very less. And this is how, when the multiple arteries or multiple veins are there, how we cut off the patch and how we, this is more of a surgical aspect. And this is how the transplant kidney look like when we have anastomosed. This is here, we have anastomosed the kidney end to end on with the internal iliac artery, but majority of times we prefer it on the end to side. This is more of technicalities how to do. And how long a transplant can be expected to last. I already told you the longest living transplant recipient is more than 38 years of transplant. The patient is in PGI Chandigarh, hale and hearty. Recently I have attended a conference by the Noto in Delhi, and that patient was called there and he's hale and hearty. So this is just right. So I end my talk that kidney transplant is a boon these days to the patients, and it should be taken up as a preemptive manner before the hemodialysis, so that the patient have a good hale and hearty lifestyle, with a quality of life. Again, I thank you so much, Dr. Vitull and MAPICON, for inviting me for the talk. Thank you so much.
Excellent talk. You know, basically what you have showed is really, really important, as we are also being aware by your talk that what physician should know, beautifully depicted. I learned so much, you know, after reading so much about renal transplant, but your masterpiece is real educative, and we are going to distribute your lecture on YouTube to everyone, every physician, so that he should know the basics, what renal transplant is, how the donor is selected, and how it is being done. Graphic representation was beautiful.
Right.
Thank you very much.
Thank you so
and
much.
I must appreciate your efforts also to bring this region on the map of renal transplantation. Because of your efforts, AIIMS is being recognized as a center for renal transplantation.
Thank you so much.
Thank you very much.
Equal credit goes to Dr. Saurabh sitting, nephrologist. I told you, nephrologist is the center
So
stone
please,
of any transplant program.
acknowledge
He is the main person.
Great.
Right. Thank you so much.
Thank you.